হ্যালো, শোনা যাচ্ছে কি?
Yes, yes, you're audible.
ওকে, ওকে, থ্যাংক ইউ।
Good evening.
Good evening, ma'am.
Ma'am.
Good evening. Am I audible?
Yes, ma'am.
Good evening, everyone. Am I audible?
Yes, ma'am. Yes, ma'am. You are audible.
Okay, thank you. Yes, so should we begin now? Or?
Ma'am, we can wait for like 5 minutes more.
Okay, sure. Let me know when you start, okay?
Sure, ma'am. Sure, ma'am.
Okay, I'm here. Just let me know.
Pranab, are we live now?
Ma'am, should we start? Uh, yeah, I think we can start now. And is the backend ready? Are we starting recording now?
Yes.
Okay, let's begin then. As you all know, Professor Sujata Mukherjee is among us. She will be delivering lecture today in an online mode. I would like to first give a brief bio note about ma'am, and then we would proceed with the entire seminar, online lecture. Professor Sujata Mukherjee from the Department of History, Rabindra Bharati University, is a distinguished scholar with research interest in history of modern India, the history of science, technology, medicine, and the environment, as well as human history. Her work critically engages with the complex historical narratives, bringing forth nuanced insights into societal transformation. She is the author of Gender, Medicine, and Society in Colonial India, Women's Healthcare in 19th and early 20th century Bengal, which explored the dynamics of women's healthcare in colonial Bengal, and situating Tagore's environmentalism, environmental degradation, and Rabindranath's activism, which examines Tagore's role in environmental activism. Through her scholarship, Professor Mukherjee has made a notable contribution to historical studies, particularly in highlighting gendered and ecological perspective in colonial and modern Indian contexts. That being said, we could begin the lecture. Ma'am, please proceed. Thank you.
Yes, I would request Ayush to start showing the slide. Slide one, would you please show? Uh, I'm going to give a PowerPoint presentation, so this slides are needed to be shown. Ayush, are you there?
Yes, ma'am, I am starting the flash.
Yes, please. Yes. Good evening, all friends and listeners in today's talk. I would like to begin by thanking the organizers for this beautiful initiative. Some of whom happen to be my students, and this is a very wonderful initiative, giving a platform for lecturing, for dialogue about various important aspects of historical scholarship. Now, I have been working on a topic which has, for the last 2-3 decades, uh, attracted attention of many scholars. And in course of my study and researches in history of medicine, where I tried to make some original contributions, and for this I have gone to primary sources in different repositories like archives here in India, National Archives, State Archives, and also there are many primary sources available in Wellcome Institute's library in London, in UK, British Museum and Library, and Rockefeller Archives in USA, which I visited some time back. And this experience of going through these primary sources led me to shape my understanding of different concepts. which are nowadays applied for studying and understanding history of science medicine in modern India. So these concepts we are going to talk about. I'm going to talk about today, and that's why I have given this title, that is Medicine, Hegemony, and Empire, and these conceptual paradigms which dominate history of health and medicine in British India. So, first, next slide, please. Yes, now here, one concept is the concept of enclavism in healthcare in India and medicine's role as tool of empire. This is an overarching concept which has dominated many writings. Now, these concepts actually encompass both ontological and epistemological issues. There have been issues of power, issue of governmentality following Foucault, the postmodernist, post-structuralist scholar, concept of hegemony, the status of modernity, and these have predominated the study of history of medicine. Now, as I was starting to analyze this concept of enclavism, which actually is rooted in this concept that medicine acted as a tool of extending imperialism. Now, that meant that medicine's role as tool of empire was propagated by scholars since the middle or 1970s, more or less. Now, before that, medicine was seen from the point of view of scientific objectivity, and it was held by the not only the colonizers but also some scholars that medicine was colonialism's noble and one redeeming feature, which means that medicine and science were treated from the point of view of scientific objectivity, not as a political or cultural construct. Uh, Later on, we see that historians and sociologists, they depicted medicine more as a social epistemology, which is socially and culturally conditioned in the same way as all other forms of human endeavors. That medical discoveries and practices can be used by people who are in power to exploit and dominate other sections, the powerless sections. For the works of Philip Cartin, Daniel Hedrick, they have pointed out and they have argued that in many areas uh, of Africa, Latin America, Asia, the European medicine and its handmaiden public health actually served to extend and consolidate imperialism in both symbolic and practical consequences. Not only that, medicine, it was pointed out that was an imperializing cultural force in itself. And associated with this is concept of enclavism in healthcare. We see that scholars who have dealt with Indian history of medicine in modern India, they argued that the medical care which developed in British period remained confined to army barracks and served the needs of European health. They also studied that it was very much epidemic oriented because in 19th century and also early 20th century, many epidemics and pandemics like cholera, smallpox, malaria, fever, plague, influenza, these uh, hampered the health of the army. So the basic needs of protecting the troops and also protecting the economic interests of the empire led to the appointment of a Royal Commission on Sanitary State of the Army in 1859. And thereafter, many sanitary regulations, quarantine measures, hygienic measures were introduced not for the general population but for the army, in the army barracks, and also in some of the cities where there were concentration of Europeans. Thus, it failed to make the transition from state medicine to public health. Productive male labor was also sought to be solved. Productive male labor meaning that sometimes the laborers who worked in plantations, who worked in some of the industries, state-owned industries primarily, like mines, there were European mine owners also, tea garden workers. So medicine was, or some amount of healthcare was given to them because otherwise production would stop, which would hamper the economic interest. Uh, Now, slide 3, please. Next slide. Yes. Now, another concept is that of concept of hegemony, which has dominated the study of medicine. Now, concept of hegemony was propounded initially by Italian politician and thinker Gramsci. And in case of India, it has been pointed out that through medicine, through introduction of Western medicine, the British they wanted to establish cultural hegemony. And many kind of medical investigations contributed to conceptualize racial, social, and cultural distinction between India and the West. A whole corpus of knowledge, body of knowledge was produced, including surveys of Indian climates, Indian environments, disease conditions, Indian soil, which represented a particular view of Indian society and culture, which was very much different from the West. So, otherization of India and the Indians happened. Indian system of medicine also was termed as unscientific, especially from the beginning of the third decade of the 19th century. So, through this hegemonic concept, it meant that there was always an attempt to control the mindset of the people of India by feeding them that the Indians were inferior to the British in many ways, and also in the field of medicine also. And Edward Said, as we all know, in cultural imperialism, he pointed out how imperialism tried to dominate the East through cultural, many kind of cultural concepts. This meant that medicine was seen as a means of social and cognitive control. Thus, hegemonic ambition of Western medicine also was represented in its attempts to penetrate the zenana or the women's quarters. Indian birthing practices, birth attendants, or midwives, or thais as we know, were demonized. They were categorized as responsible for maternal and infant mortality. However, despite this rhetoric condemning Indian practices, there were actually negligence of extension of healthcare facilities for women and common population. A study, if we study epidemic policies, we know that how economic imperatives dictated the nature and measures of epidemic control policies. We see that from the mid 19th century, different institutions were built up through which Western medicine wanted to extend its hegemonic control: hospitals, dispensaries, medical schools. were established, and 1835 Calcutta Medical College was established, which was also supported by the Indian elite because they supported the cause of science and Western medicine. Now, along with it, on the one hand, we see there was attempt to build up many colleges, many schools, extending medical knowledge based on Western medicine among the people. At the same time, there was also this otherization and demonization. Next slide, please. So, otherization side by side with extension of medical education went on otherization and demonization of Indian practitioners of different therapeutics. I have pointed out about midwives. There were other institutions as well, like Ayurvedic institutions were there, Unani medicine. So there was vigorous denunciation of indigenous healers. We always see that medical discourses which were produced by the colonizers, these were impregnated with the language of race, preoccupied with the need to preserve European culture, European mindset, and the Indian healers who were actually performing an important function of giving some amount of medical care where there was none to general people, especially the rural and urban poor. They were called the witch doctors, the Vaidyas and Hakims. They were also denounced. It was said that their practices were grounded in superstition and at best empiricism. Thus, at one point of time, we see, especially from the mid 19th century, it became common for the practitioners of Western medicine, especially the Western doctors, to assume a hostile attitude towards the Indian healers or practitioners of Indian medicine. And it was said that Western medicine is an indisputable evidence that colonial rule stood for rationality and progress, whereas indigenous society cherished superstition and witchcraft, ruled by ignorance and cruelty, held beliefs and practices Europe have left behind uh, in the Dark Ages. We also see that there was spread of European germ theory in the 1880s and so on, and laboratory medicine also grew. And these were represented as a crusade against disease germs and also against social and cultural prejudices of the tropics. Indian system of Indian system was seen as harboring many beliefs, very much prejudice and everything. Scottish physician Patrick Manson established School of Tropical Medicine in Great Britain. Main purpose was to research malaria treatments, which would ultimately stimulate cash crops and the economy, which would again serve the imperial interest. We also see that during cholera epidemic, which started from 1817, on the one hand, the rural people, their uh, bad sanitary habits were blamed for uh, extending this disease, but there was no extensive good measures like better water supplies were taken or better sanitary measures were taken because, of course, of lessening the financial burden. And again, at the same time, we see that when in the 1890s the plague struck, then there was too much repressive measures, and there was also protest because the European powers, they were saying that if plague was not controlled in India, then they would stop trading with British India. So this need again to protect the economic interest. Now, what we see that medicine kind of provided justification for imperial rule, and benefits of Western medicine were identified with Europe's civilizing mission. For example, Rudyard Kipling, who said that it was part of white man's burden to civilize the barbarian Indians and also to protect them from various bad habits and diseases. In the 1880s, we see that many Janana missions were established to provide medical help for Indian women, and it was pointed out that Indian male, they were not serving well, they were not taking care of the health needs of the Indian women. So only the imperial women could look after Indian women. Here we see that from the 1880s, by creation of Dufferin Fund, a medical association for helping the Indian women, uh, it also again provided a kind of justification of uh, imperial rule, the beneficent aspect of imperial rule. And there was also what is known as feminization of imperialism. That the female imperialists, the governor's wife, even Queen Victoria, they knew about the needs of the poor Indian women and they came forward to look after them. Lord Curzon, it is very interesting that speaking in 1899, Lord Curzon claimed that the British had come to India not simply as conquerors, but also as benefactors, bringing their religion, law, literature, and science with them. So we see that there is hegemonic um, ambition and otherization of Indian practices went hand in hand, and also peripheralization of Indian practitioners in the whole medical system. Next slide, please. I'll talk about, yes. Now, this is very important. Foucault, the post structuralist influential theoretician who wrote very important books like Birth of the Clinic, he showed how in the West this clinical medicine uh, it replaced bedside medicine, and many changes were happening in the 18th from the 18th century. Coming of the biomedicine was happening in the West. He did not talk about the Eastern colonial societies, but those who have worked on medicine in India and other parts of Asia, they have utilized Foucault's concept of biopower and governmentality in analyzing history of Western medicine. That is, it is pointed out that the government's wish was to control population. So we see that whenever there were certain steps taken, like in the from the mid 19th century, we see sanitary commissions were established in different provinces. The first important task was to collect statistics about birth and death. So this collection of vital statistics, also trying to know about habits of Indians, it was a need to rule them properly. To rule them properly was to or should be based on knowledge about this. This is the concept of biopower that they wanted to control through medicine and application of this kind of disease control and some amounts of public health um, institutions' growth. They were trying to control and govern the people because Foucault has actually presented a concept of power which was not exactly that of sovereign power, but a power which could be seen in different institutions like jail or in the clinic, also in growth of many kind of hospital medicine. Also, there was a need for controlling the people. Why? Because they wanted good, productive bodies. And herein also, we see this concept of colonization of the body that has been uh, pointed out by many scholars, that imperial medicine also meant a kind of colonization of the body of the Indians. As I said, that now the state was trying to establish its control over the mind and the bodies of the colonizers. For example, when the vaccination policy for smallpox vaccination was introduced, the state wanted to say that through this vaccination, by Indians, by taking vaccines of uh, smallpox, they would themselves be cured or prevented against smallpox, and they would also stop from infecting others through um, this disease. Now, during smallpox vaccination, we see that there was also an age old practice called known as variolation among the Indians. So, in Bengal, it was called Bangla Tika. Now, the British pointed out the Janarian vaccination was far, far superior than Indian system of variolation. So, but the Indians in many cases were very skeptical, because it was seen in many cases that after taking vaccination, people were also dying, because there was no proper preservation of the limb, the cow limb, no proper system of preservation till the late 19th century. So the vaccine itself became polluted and people were dying. So there was a kind of mistrust between the colonizers and the colonized people. So they refused in many cases to take vaccination. And also there were also this age-old practice of variolation was effective in many cases. Not that these were always uh, very bad. So there was a kind of lack of trust. That's why it in Bengal at least it progressed very slowly. In other countries, in other areas, it was progressing in a good manner. Now, so this colonization of bodies happened, and during plague we see that there is forcible hospitalization, there is forcible quarantine measures were taken, because the here we see the state was claiming that this disease struck bodies, these had to be controlled by the state practices of quarantine measures, forcible hospitalization. And there was a conflict. It became a very much contested concept. Next slide, please. Another interesting concept I will talk about. Next slide. This is the concept of medical pluralism. And now, of course, I have talked about the otherization, Germanization of the practitioners of Indian medicine. But rhetorically, it was done. At the same time, now scholars have pointed out that the British could not totally eradicate or obliterate practitioners of indigenous medicine or Indian drugs, because they had efficacies. So they actually, at the ground level, we see that in the dispensaries, in many hospitals, the Indian drugs, it was called native drugs, bazaar medicine, those were used. And many Indian doctors who were trained in Western medicine, still, when they were serving Indian population, they made a kind of, they were following a kind of practice which was kind of hybrid. It's a mixture of Western and Indian systems. They would use local herbs, local Ayurvedic pills also. And the imperialists themselves also, initially, they also uh, investigated many Indian local flora, local herbs, so that they could make new drugs from them, which could be added to European pharmacopoeia. So there was selective appropriation of indigenous medical ingredients and methods into modern medicine. That's why what we see in India, in British India, was just not conflict and context between Western concept of disease, Indian concept of disease, Western therapeutics and Indian therapeutics. We also see that in many cases there was pluralism, medical pluralism, where there was coexistence of different varieties of drugs and varieties of practitioners. But they thrived on their own. The British neglected them, the British always held a superior attitude, and where they could help, particularly for the British Army and the British people, there were hospital care through Western medicine. But the general masses, 80-90% of them, had to depend on local herbs, local healers. So that was the scenario, and this concept of medical pluralism has nowadays remained a very dominant conceptual paradigm. Next slide, please. Yes. Now, history of medicine is also very much related to the aspect of modernity, tradition, that how far modern and traditional Indian society chose to remain by adopting Western medicine and traditional medicine. And this medical care, this issue of medical care, public health, also in many cases dominated nationalistic feelings. We see that Western medicine became a critical issue in the growth of anti colonial movements. Many nationalists, many traditionalists sought the restoration of old medical beliefs as part of their assault on Western colonialism and cultural hegemony. On the one hand, we see that there were Western educated politicians, indigenous practitioners of Western medicine who resented the racial exclusivity and narrow priorities of colonial medicine. They argued for a freer distribution of the benefits of Western medicine. They said that it should reach the common people and should not be confined within the elite section of the British and the Indians. So, this medicine, public health, as became occupied a central place in the program of nation building, economic development, and critique of colonialism. Now, we see, of course, that because of this kind of criticisms more and more developing among the Indians, the colonial medicine kind of was forced to cast its net more widely. The colonial governments was very cautious that um, they wanted to avoid a lot of expenditure and efforts also. And we see that from the 1880s, when there was growth of municipal governance and all that, public health was transferred. The responsibility of public health was transferred from the 1880s to local government, municipalities also. Now, this was happening in England also, that municipalities they were becoming responsible for public health. But in Victorian Britain, the municipalities were also allotted many funds. But in India, that was not the case. Funds, there was always shortage of funds because the imperial government always said that the local people should be taxed to carry on the municipal efforts. Now, Hindu, Ayurvedic, and Islamic Unani systems, India's classical medical systems, initially faced a period of decline, official hostility. Later on, found fresh patronage from the middle classes in the late 19th, early 20th centuries. And these became part of country's revitalization movement, nationalistic movement also. During non-cooperation with civil disobedience, many nationalistic schools for teaching Ayurvedic Unani medicine and associations were being built up for carrying out this agenda of cultural nationalism. Now, in the Indian countryside, as I was saying, that there was very slow advance of Western practice. Even by 1947, we see that in the countryside there was predominance of folk healers and folk medicine. This uh, continued to happen. And now another thing which have affected or which have contributed to the development and growth of colonial medical history is uh, the post-colonial writing of history. Now, next slide, please. So, this post-colonial writing of history, we see that two themes became very dominant, which also affected history of medicine. One was this theme of decolonization. We see that from the this mostly from the 1970s, we see that there was a lot of study which focused on recovering the lost voices of imperial history. There was gradual democratization of colonial societies, the rise of political and social rights movements in uh, recent years, and general political mobilization of different sections of population. So the voices of a wider section of marginalized population like women, lower castes, or so-called lower castes, I should say, tribes, peasants, laborers, were being heard and recognized. And these sections also demanded their own histories. There was a sense of loss and the need to which Edward Said also talked about. That there was a sense of loss and the need was felt to recover the lost voices of the past. This became an important preoccupation of imperial history writing from the 1970s and more so 1980s. This, as I said, an important feature of Said's analysis of cultural imperialism was this sense of loss of identity, loss of culture and history in the process of colonialism. So, uh, imperialism was seen as a dislocation, the disruption of indigenous cultures, knowledge, traditions, and a loss of agency of the indigenous people. So it was said that there should be decolonization of this history writing. We should come out of this colonizing concepts. And several colonial countries, they were gaining independence and they set out on the journey to reconstruct their nations and cultures and identities, which were perceived as being lost during colonialism. Thus, this post colonial nationalism was a very important reason why the writings of Said and others became so much influential. And it also kind of influenced the studies in history of medicine. That is, they were the historians like us, we are trying to focus on gender or on other aspects, on the class aspect and the caste aspect, on tribes or indigenous people's lives, how medicine affected them, and how they were getting healthcare and all that. This theme became very important. Decolonization theme became important in history of medicine. Now, next slide, please. This was another major turning point in the writing of imperial history, which came from the 1980s. there is emergence of subaltern studies. Now, subaltern studies was formed by a group of scholars who came from various disciplines, wrote about the colonial and post-colonial experiences of ordinary people. They also stressed the need to identify the autonomous subaltern domain, which was considered to be a complex collective of people defined against the elite domain. And this comprised marginalized groups, so called lower classes of the Hindu society, poor people, and Janajatis, who had been rendered without agency and voices to elitist and imperial policies and history writings. So this appeared as a particularly useful concept also in history of medicine, that how subaltern resistance was seen against many kind of imperial medical policies. Next slide. And very much related to this is this concept of history of below within colonial medical history. There was on the one hand these grand narratives of transformations. That is, the imperialism came with Western medicine. They tried to dislocate the indigenous medicine and all that. This was a grand scale transformation. Now, historians are trying to focus on the agency of the colonized people, the history of traditional medicine. That it was not that the traditional medicine was not there. So how the people who were practicing the traditional medicine or the different kind of you can say tribal healing practices, bone setting practices, and all sorts of practices, how they reacted, what was kind of their lives going on. So this is we can call it history from below, not focusing just on colonial imperial strategies, their interaction with elite people, but also focusing on the history of people who belong to the lower strata of the society. And thus, what we see that the historians stress the role of medical professionals, healers, and also patients in India, and engage creatively with history of medicine, often define their application in unique ways. And also they wanted to modernize. It is true that many Ayurvedic practitioners, Unani practitioners, they were trying to modernize their indigenous medicine. There, here also the history, the concept of modernity comes in, that they wanted to retain their traditional views. At the same time, they knew that to compete with the Western system, they had to a certain extent embrace modernity. So modernity also remained a way of looking at how transformation in this health practices happen. Now, a prominent example of how medicine led to this formation of and expression of collective identities, we can cite the example of David Hardiman. He made a very important study of smallpox and the cult of Devi in tribal Gujarat. And Hardiman showed through his study that the Adivashis of Western India in the early 20th century evoked the cult of the goddess, a Devi, and its accompanying commandments on cleanliness, diet, to counter the threat of smallpox epidemics. So this was also a mode of collective assertion against the locally dominant elite, like the merchants and the landlords. So you see that these kind of studies are very much new, and these are also happening. Thus, historians today are more willing than their predecessors to view colonial medicine through the experiences and perceptions of those who came under its sway, and willing to see European medicine as um, not necessarily only one acceptable and efficacious among several competing systems of health and healing. Now, the last slide, this concept, this biomedicine, how it served the public health. This also remained one very important arena of historical studies. We see that from the 1850s, in India, that dispensaries, clinics were established to a very small extent in the countryside. From the 1920s, there are also attempts at mobile dispensaries. But remember that always the funding um, had to come from voluntary agencies like the landlords who were there in the countryside. And sometimes the missionaries also helped, like asylums, leper asylums, they were building up. Certain organizations, individual philanthropies, they were building up. And the imperialists, they were making small donations sometimes to support these efforts. But later on, they would often withdraw their donations also. So there was very little fund from the imperial exchequer coming. Later on, we see that there are also many kind of researches by both the Europeans and the Indians on the problems of malnutrition, rural hygiene, women's and children's health happening. But all along, mostly we see that the colonial state had very narrow priorities, and Western medicine was also, at the end of the British rule, was very thinly spread. We see that on the eve of Britain's departure from India in 1947, there was only one registered doctor who was practicing Western medicine for more than 6,000 people, and only one nurse for every 43,000 people. If you compare it to Britain, you would see the difference. There, one doctor per thousand people and one nurse for every 300 in Britain. So you see how much that negligence of health, especially for the rural and urban poor, happened. Health infrastructure that was developed, of course, dispensaries, hospitals, clinics grew up, mental asylums grew up, but they remain very much urban centric or city centric. And the urban poor, rural India also suffered. So, despite criticism, little actually was done for delivering Western medicine to the general masses. That is why we see that nowadays the historians who do, like our social history of medicine, they focus on everyday lives of common people to reconstruct the history of uh, medical past, their beliefs, their healing systems. A very famous historian, Roy Porter, who worked on Britain, he moved this focus of history of medicine from great doctors, scientists, to everyday lives and stories of people, day-to-day life of people. And society emerged as one important area, not only the state, but society emerged as one important area of studying the role of medicine. It gave voice and visibility to a new set of actors such as the patients, the nurses, drug peddlers, middlemen, and led to a new way of looking at medical artifacts, institutions such as bedsides, laboratories, hospitals, drugs. Thus, these historians nowadays are offering a new way of understanding medicine as a social process rather than unfolding of a universal system of knowledge. Now I rest here. Thank you.
Hello.
Yes.
Uh, I would now like to open the floor to question. If anybody has any questions, please raise your hand. If not, I can. I have some questions based on
Please, please.
the entire lecture. My first question is in what way colonial health policies contributed to the creation of hyperreal narratives about disease native in the sense of Baldur's simulacra.
Sorry, can you expand a bit? I just couldn't hear you properly. The terms you were using.
My question is how colonial health policy contributed to the hyperreal narratives of disease native. I was also reading Swami Vivekananda's basically a piece when he was moving to Chicago, like through boat. There he mentions that every native Indian was checked thoroughly if they're carrying any kind of diseases, whereas Europeans they're thought to be they are pure and they cannot be diseased, so they have a separate cabin and they were not uh, basically checked as thoroughly as the Indians were.
Yes, because there was this was already, as that was I was trying to make this point that there was this kind of otherization, of total that east-west distinction, and the habits of the Indians were seen as very much by Western standards. These habits were seen as very much dirty. They had no regard for sanitary policy. Uh, they don't know the basic rules of hygiene. So this narrative, there was this kind of narrative, and this happened. What Vivekananda saw, this happened earlier also, and maybe this mindset was seen. Especially, this was built up when there was cholera pandemic, uh, which cholera started. Now, cholera was there even before 1817, and cholera was actually spreading in India after 1817, and so through troop movements, there are a lot of wars happening with the East India Company, and troops were being moved from one place to another, movement of traders, and all those things. So cholera was spreading like that. But the whole focus was on the habits of the Indians, the pilgrims. It was called the pilgrimage, Indian Hindu pilgrimage, and the Hajj. Those travelers, they were seen as the vectors of the diseases. So there was quarantine measures were against them. So this was a whole kind of, as well, since this cultural thinking that these Indians are far inferior in the scale of civilization, and this mindset actually dominated the narrative, and this percolated everywhere. That was the kind of mentality, you should say, that which was always a perception. This was a kind of perception of the Europeans. Now, I would also like to suggest that, for example, even Nivedita herself, when she was doing plague relief work, I wrote a small piece in Anandabadar Patrika in Bengali. And in traditional books like uh, historians' books, it is not very much mentioned. It was said that during plague in Calcutta, Ramakrishna Mission did a lot of work, and Sister Nivedita herself do, because Swamiji and other sannyasis took a great role, performed a great role. They were going and serving the Basti people in the slum areas. And the British officers were always blaming the slum areas within India. Mostly they were blaming the practices, unhygienic practices of the slum people for spreading diseases like cholera, plague as well. Actually, it was happening because there was no uh, clean water supply there. Sister Nivedita herself said that, well, the British administrators, they say that these Indians, they cannot be changed. But I have talked with them. I have taught them about the rules of hygiene, how to maintain them. Nobody teaches them that, and uh, their poverty is actually the main reason, because they could not afford to clean it, and they were always having poor health because of poverty, because of malnutrition and everything. So it was a kind of uh, um, what is also known as orientalization of medicine, because the Orient is always this hotbed of diseases. It was said the Indian cholera, it was the epithet used, the Indian cholera. Mm. It was seen as spreading from India and all that. Although Mohandas Sarkar and others actually proved that the cholera germs which affected people here was not the same germ which was causing cholera in Europe and Britain. But the imperialists did not care about it. Does it
Yeah. It
answer?
clarifies my doubt. We received two questions on the chat box. One was the hegemony of Western medicine an example of coercive hegemony or soft hegemony, given that Western
Is
medicine was
this
more
in the
scientific?
yeah,
It is by Rajiv Roshan Ghosal.
Rajiv Roshan was the hegemony of Western medicine? Was the hegemony? Yes. Hmm. This is a very interesting question. Now, and this is a tricky, very intriguing question also. That now, I would go for the fact that this hegemony was partly coercive and partly soft hegemony. Because in the why I say so, because in some areas like that spread of Western medicine to establishment colleges and all, that was kind of the elite Indians' agenda also. It was not totally forced on them. They accepted, they donated also. That's why I call it not so much coercive actually. At the same time, I would say it was semi-coercive because, as I said, during cholera, they did not want to impose quarantine. They said that this would create a kind of reaction, people's reaction, anger. But during plague, they did not care about that. There was coercion that who refused to take vaccine or refused to be hospitalized. The army in Pune and the plague commission, they forcibly the army was deployed to enter within the household and they took out people forcibly from inside their home and hospitalized them. There was also resistance to that, of course. So partly it was coercive hegemony and partly soft hegemony. I would say. Yes, it was scientific, it was effective. That's why the one section of the Indian elite, they accepted Western medicine and they wanted that people should get more and more the advantage of this medicine. You know. Yes, and even the Ayurvedic, I would like to add the Ayurvedic practitioners as well. There was two sections among them. One was the purist, and the other was the syncretist. The one said that we need to follow the pure Ayurvedic system, and the other said no, we need to make a kind of we should know about Western sciences of anatomy and physiology also. They did not want to do dissection of human bodies, but we need to know about the anatomical. We need to need also to gain anatomical physiological knowledge and then mix it with our Ayurvedic concepts also. So they are also thinking of embracing to a certain extent uh, this scientific medicine environment. Any other question?
Ma'am,
Is there
should I spell
anything?
out the questions?
Sorry?
Ma'am, should I spell out the questions?
Yes, please.
Yeah. So the next question is done by Rakhi Mondol. Did colonial medical practice function as a form of epistemic violence, as suggested by Gayatri Spivak, erasing subaltern knowledge system in health and healing?
also that you see that maybe at certain level, but uh, no, erasure of subaltern knowledge system. I don't think that happened actually, because if that could not be, that could not cater to the subalterns, they had to depend on their own knowledge. That was basically not codified knowledge. So it was a kind of oral tradition, and that oral tradition was kept alive generally by generations after generation. Uh, uh, Healers within certain generation. They had their own practices. So it was a practice because that was followed through ages. So how could those be erased? I mean. Uh, imperialism could not really want to make inroads into this knowledge, obliterate this altogether. I mean, did not take any steps. Also, they did not take any steps to preserve this. Okay, so I don't think that is you can call they took aggressive measures. If by epistemic violence, I mean they became very aggressive. They aggressively obliterated those kind of knowledge. Um, I don't think that happened. Maybe their intention was they were propagating against that. The rhetoric says that these are demonic and all that. It is unscientific, dangerous. They were saying that, but at actual level, actually, kind of totally obliterating that. That happened, I can say, in case of smallpox, there vaccination laws were made, uh, where variolation, the Indian practice, was termed as illegal. That law was there, but that law was also not put into practice everywhere. There were loopholes also. But they were not forcibly practicing that law also, because there was also kind of fear of um, backlash. Yes.
Uh, the next question is done by Rajiv Roshan. How the NGO played an crucial role to escalate the Western medicine among the rural people.
That is also very important. Now, by NGO, of course, during that period, there were certain in Bengal. I can say that there were kind of cooperative malaria societies, cooperative cholera societies, and the philanthropists, the Red Cross organization later on. Tagore was also this addressed this cooperative malaria society, and also this anti-cholera society. They were treating people in Western hygiene. No, in hygienic practices, in sanitary practices, they were treating people like that. But if you say that escalation of Western medicine among the rural people, um, to a certain extent, yes, you can say they wanted to make people aware of certain rules of sanitation and hygiene uh, um, among them also. It happened to a certain extent at certain levels. So partly it happened. Yes, partly it happened.
The next question is done by most probably Ayush. How did the colonial medicine infrastructure create Boulderian hyperreal spaces such as sanitariums and hospitals that projected illusion of serving care, serving imperial interest? The question is kind of complexly wrote.
Now, whatever colonial medical infrastructure was built up, as you see it, of course, it projected an illusion of care on the one hand, and Serving imperial interest, yes, of course. And I would like to add that when we talk about serving imperial interests, I would talk that they reflected in many places a racial attitude. Hmm? Racial attitude, meaning that, for example, I give you an example like when there was this in the 1820s, 1830s, 1840s, in different hospitals, the medical college hospitals, and there are other hospitals also. Mostly Europeans were treated, but there were one or two hospitals for general people. Also, very few beds were there. But within those hospitals, uh, certain beds were allocated for the European patients, and the food, the diet which they got and they were allotted was far superior than the Indian patients. So within these, there are native words, there are Eurasian words, there are European words, Eurasian words, native words. The native words were the worst. So in that case, of course, we see that this racial outlook was expressed here as well. And now, when you say one thing is needed to be kept in mind that when the imperial interests meant, in this case, keeping Europeans healthy and alive. So, to a certain extent, they also understood that to to make the European quarters of a city or the army barracks disease free, the people who live in the Indian quarters, for example, in Calcutta, there was White Town and Black Town. So these people the natives who were residing in black towns adjacent to the white towns, they also needed to be their area, their spaces should also remain germ free and disease free. Otherwise, they would infect the people who were residing in the um, European quarters of the city. So in that way, that's why I was saying it was urban centric, it was city centric, because wherever there was concentration of European armies and European um, civilians, nearby the native people, they were aware of the fact that nearby people living in nearby areas should also be taken care of so that they don't infect the Europeans. So, in that way, they were serving the imperial interest by serving to a certain extent, to very nominal extent, the Indians as well. They had to do that. So, that was also serving imperial interest as well. And would you say that creating and yes, that was their no, that was of course their objective was that. But then later on, of course, that is why I was saying that the nationalist critics they criticized this colonial authorities for not giving the public enough health care, not serving the people well. Uh, so criticism also came later on.
And the last question I've received is Prashant Kumar.
It's,
He queries about the existing hybrid system of medicine in rural society under colonial rule. She asks, especially in case of dispensary medical system, both indigenous and Western medicine are working together. Do you think there was a form of cultural plurality than so-called cultural context of hegemony uh, that existed in the periphery of British rule?
Yes, as I said, I have pointed out, I talked about medical pluralism. I did not use the concept medical hybridity because hybridity is a different concept. Hybridity means something else. So I would like to use this medical pluralism because, as you say, that in the and I have pointed out exactly what you have said that in the dispensaries mostly the indigenous and Western medicine were working together, no doubt about it. The dragas in the herbal remedies were prescribed in many cases, and the doctors, the sub-assistant surgeons, they were actually applying whatever was available there. Mm, and in most cases, they're prescribing these herbal drugs as well. So there was entirely a system of medical uh, pluralism, especially in the rural areas where drugs were Western medical drugs or drugs which were prescribed in Western pharmacopoeia were not readily available. In the rural areas, they had to depend on Indian medicines, Indian drugs. And so, of course, that was there. But at the same time, yes, medical pluralism. At the same time, when they were teaching medical systems, they were talking about European pharmacopoeia. Yes, it was the scientific basis. But in actual, at the ground level, they had to practice medical pluralism. Thank you.
Okay, we have arrived at the end of today's lecture. We have received more questions. Thank you, ma'am, for delivering this
Thank
awesome
you.
lecture. We thoroughly enjoyed it, and it's our pleasure that being the audience and hear such gracious lecture. Thank you, ma'am. Thank you from the side of Voices into the Periphery,
Thank
and
you very
good
much.
evening.
Thank you very much. It has been a
Uh,
especially enjoyable experience for me as well.
yeah, and this lecture will be recorded and then posted in YouTube in subsequent in today or like subsequent days. Thank you.
Yes, thank you.